So what I'll basically talk about is the role of interventional radiology in the management of metastatic colorectal cancer. And nicely, Dr. Saif and Dr. Hassanin set the stage for me and made it very easy for me. So basically, what I cover is the this is the pointer. Okay, this one. So what I'll basically cover is the liver-directed therapy. I'm not going to talk about the other things, which are the oligometastatic disease to lung, bones, and the tumor marker implantation. So basically, I'll cover the percutaneous ablative therapies as well as the transarterial chemotherapies. So pretty much everything we do for metastatic colorectal cancer is translated from the hepatocellular carcinoma. But with some technical differences, specifically for the percutaneous ablative therapy and the amount of literature we have to support or avoid doing these kind of therapies. So for the RFA, for the radiofrequency ablation, as Dr. Hassanin said clearly, anything smaller than 3 centimeter, we have very good chance of achieving complete response. Almost approximately 90% if the lesion is smaller than 2 or 3 centimeter. And the larger the lesion, between 3 to 5 or more than 5 centimeter, the chances of achieving complete responses start dropping dramatically. And this is provided that the lesion is clearly visible for us by ultrasound or CT or any kind of imaging guidance. And the lesion is located away from the biliary radicals to avoid biliary complications. And the lesion is away from the large vessels. What we mean by large vessels is 3 millimeter. And any vessel which is larger than 3 millimeter will cause the heat sink effect. This is specific for the radiofrequency ablation. And once the lesion gets closer to a 3 millimeter vessel, then the chances of incomplete response increase by 23%. So if the lesion is smaller than closer to a vessel, then the chances of complete response will start decreasing. So what kind of evidence we have? So as Dr. Saif said, this is a new subject, a new kind of treatment that we are applying to our patients, and the literature is not so robust in these. However, there are some good, starting to build up good research now and good trials. This is a trial comparing radiofrequency ablation to, with chemotherapy to chemotherapy alone, systemic chemotherapy alone. And this is the trial actually. It's a large multi-center trial from Europe, Eurotech. It's an intergroup phase 2 trial which randomized 119 patients who have metastatic colorectal cancer to liver. 59 of them they were randomized to systemic therapy alone. The 60 patients were randomized to systemic therapy plus radiofrequency ablation. Some of them actually underwent resection as well at the end. So that trial was in favor of the radiofrequency ablation and systemic therapy, and shows that radiofrequency plus systemic therapy improves progression-free survival. However, the overall survival was almost the same for both arms. So adding radiofrequency ablation to systemic therapy will improve the progression-free survival, but ultimately the overall survival will be the same. So now the other question that we have to answer always, which one is better, RFA or resection? And actually, Dr. Hassanin answered this question nicely as well. There's lots of data on this, by the way. This is one retrospective study that shows this is comparing 32 RFA patients to 60 patients who underwent resection for metastatic colorectal cancer. And the local recurrence was much lower with the resection, as you can expect. Radiofrequency ablation, for so many reasons, lesion size, proximity to vessel, proximity to capsule, proximity to biliary radicals, maybe incomplete visibility or incomplete coverage of the lesion by the RFA probe, that will ultimately result in incomplete response, which can be as high as maybe 50 or 45% of the cases. So, and interestingly enough, if the lesion is smaller than 2 centimeter, we can get very good results. There is no difference between surgical resection or RFA. So the conclusion from this study, RFA is good for lesions smaller than 2 centimeter. If the lesion gets bigger than 2 centimeter, which is obviously, surgical resection will do better job. So this is a meta-analysis of all 20 studies addressing this specific question specifically. Almost 10,060 patients underwent RFA, 1,800 patients underwent resection, and just a few notes from the demographics of these patients. All of the RFA cases, they had smaller lesions. They're not surgical candidates, as you can see. ASA was higher in the RFA arm. Most of these patients underwent neoadjuvant therapy before, and less of them underwent adjuvant therapy afterwards. And the complication rate, as you would expect, was lower with the RFA arm. And the shorter hospital stay. Most of the time, we do RFA on one-day admission. And there was no difference in 30-day mortality. And not surprisingly, RFA showed higher rate of recurrence, as you would expect as well, odds ratio of 1.66. And the 5-year survival, disease-free survival, and overall survival were lower with RFA. So technically what I'm trying to say, RFA is not as good as resection, but if you choose the proper patient, proper lesion, proper location, then the chances will be probably as good as surgical resection. Now, the new modality, which is the microwave, which we have in our institution, so many questions arise regarding the microwave. Is it better than RFA or is it worse? What are the differences? In terms of technical differences, microwave generates higher temperature. This is one. It's faster. It's technically easier for us because there's no pads for the patient, less chances of causing skin burns for the patient. And there's no heat sink effect associated with microwave because the probe itself generates the temperature as compared to the RFA, which is a circuit of electricity going through. If you have a current or a flow next to it, it will eliminate the temperature immediately. The microwave will generate lots of temperature as high as 100 Celsius as compared to the RFA, which is probably around 60. And if it gets closer to small vessel, to a large vessel, then the temperature will drop dramatically, so it will not achieve good response. So which one is better now? This is a retrospective comparison of matched cohorts, 254 tumors, 127 per each group. And it sounds like microwave performs better in terms of complete response. There was only 6% recurrence rate with microwave as compared to 20%, which was statistically significant. So because of the higher temperature, I think microwave does better job than RFA, provided you select the right lesion, the right patient. And this shows the early divergence of the survival or the ablation site recurrence rates. Microwave does better job compared to the RFA. And now the question is for us, at least technically, is microwave better than RFA in perivascular or peribiliary? If the lesion is centered in the near the bile ducts or next to a big vessel, which one is better? This study answers this question. 774 unresectable colorectal metastases. They selected 122 patients with almost 200 lesions. 160 were perivascular alone, and the rest were peribiliary plus perivascular. So it sounds like for perivascular lesions, both microwave and RFA do the same job. They're as equally safe and effective. But for if you get close to biliary radicals to the center of the liver, then the chances of getting biliary complications with microwave are higher. That because probably of the temperature generated by the probe itself. So again, patient selection, lesion selection is the key in these patients. So if we are very careful in selecting the patients, then we can achieve very good results with the least possible complications. Now, changing the type of modality that we can use for these patients is the transarterial therapy, which can be either chemotherapy, chemoembolization, or radioembolization. So the chemoembolization, and this is another translation from hepatocellular carcinoma, but using different type of chemotherapy, which is irinotecan. And recently, the drug-eluting beads, which can absorb the irinotecan, then start releasing the irinotecan immediately inside the tumor. That was started maybe in 2006. So preclinical studies showed that what we call debris, drug-eluting beads irinotecan, improves the pharmacokinetics of the irinotecan. So once you inject it, once the beads are deployed inside the tumor, within 1 hour starts releasing 90% of the irinotecan. After 2 hours, 98% of the irinotecan is released completely. Comparing the concentration of irinotecan per 200 milligram of the tumor, debris delivers way higher doses of irinotecan inside the tumor as compared to the IV because of the first pass issues, and so that generates a very large amount of irinotecan delivered immediately inside the tumor as compared to IV alone, almost like maybe 150 times higher concentration. So do we have evidence to support or go against debris? Yes, we have, and it's a randomized clinical trial. And this is the first one, actually. It's comparing debris versus chemotherapy alone. This is intraarterial infusion of drug-eluting beads versus systemic FOLFIRI. And this is multi-institutional trial comparing 74 patients, 36 for debris alone. These patients are chemo-naive, by the way, to FOLFIRI, 38 patients. Interestingly, debris did better in terms of the overall survival at 50 months. 15% were alive at the end of 50 months as compared to 0. And the progression-free survival was better, which is 7 months compared to 4 months only. There was no significant difference in the extent of extrahepatic progression. And this is probably the most important finding, probably as oncologists, palliative physicians, the quality of life, the duration of quality of life, improved quality of life was 8 months, which was significantly better than 3 months with FOLFIRI. This is probably very good in support of the use of debris in these cases. Now, in terms of response, was better complete, this is what we call objective response, complete plus partial. Complete plus partial or objective response was better with the debris arm. Stable disease was better as well. Probably, I don't know how much significant, but ultimately the overall survival was what's your interest. Toxicity, not surprisingly, because of the lower concentration of systemic irinotecan, was lower, specifically neutropenia, more than grade 3, and the mucositis is way less with the debris, 1% versus 20%. The change in LFTs and bilirubin was very transient, went back to normal after 3 weeks, but it was as you expect because it's embolization procedure. You will have elevation in LFTs and bilirubin. Now, there's another trial which is debris plus chemo, which is FOLFOX, compared to FOLFOX only. This is also another trial comparing chemo-naive patients, modified FOLFOX and Avastin in 30 patients, FOLFOX and debris in 40 patients. Both they had 30% liver involvement. They received the same median number of chemotherapy cycles on both arms. Interesting demographic thing is the patients who were treated with debris, they had higher grades of EGOT, 1 to 2, 57% of them were at least 1 to 2 in the debris arm, and they had more extrahepatic disease. So the overall response rate was much better, significantly better with administering debris directly along with the chemotherapy. As you can see, 78% they had complete overall response rate at 2 and 4 and 6 months, and significantly more downsizing to resection when you administer debris, drug-eluting beads, transarterial, and also improved the median progression-free survival, 15 months versus 7 months. And the literature is building up. As you can see, you have so many trials not trials actually, only randomized clinical trials here at the top, and the rest are prospective registries with different endpoints and different median overall survival. But at the end, literature is building up. It might take some years to just confirm or go against this type of treatment. Now, the last thing, which is probably the most interesting thing, is the use of selective internal radiation therapy, which we call radioembolization. And this is another translation from hepatocellular carcinoma. And we used it for cholangiocarcinoma and neuroendocrine tumors and metastatic colorectal cancer. And there's a large trial, which is probably all you know, FOLFOX, and there's actually a combination of 3 trials. It's the radioembolization plus chemo as a first-line therapy compared to systemic chemotherapy. This is the first, they call it Foxfire, Surflox, and Foxfire Global. This is a combination of 3 randomized clinical trials, almost 1,000 patients, 550 almost for FOLFOX, and 550 for both systemic and radioembolization. And this is this table shows the extrahepatic metastasis at the time of beginning of the randomization. Large proportion of these patients, they had extrahepatic metastasis at the beginning, and more than 25% of liver involvement was almost the same in both arms. 30% of them, they had more than 25% of liver involvement. This trial was not in favor of radioembolization. So just to show you, the survival was not different between the 2 arms of the study. There was no benefit of adding the radioembolization as a first-line treatment in these patients. And as you can see, the median survival time was almost like 23 months for both arms, not much difference. Progression-free survival was not statistically significant. And also, the median progression-free survival was almost the same for both arms. So nothing was frankly positive. However, the liver response was better with the radioembolization arm because you're directly hitting the liver with the radioembolization. However, the extrahepatic recurrence was higher with the systemic therapy. So, and also there was no difference between patients who ultimately go for resection. Both arms, they had the same number of patients. And the only problem with adding radioembolization is the complication related to the radioembolization. So there was significantly higher number of patients who get a grade 3 or worse complications following the radioembolization. So that was the drawback of this kind of treatment. However, they did subgroup analysis. This is probably interesting finding for patients who had right-sided primary. I don't know, from the surgical standpoint, probably it's different if you have right-sided primary. But this is what they found, that the patients who had right-sided primary, they were almost like 180 patients. They did better with applying radioembolization as a first line along with the chemotherapy. The overall survival was significantly better in these patients. It was 22 months compared to 17 months. I don't know how much 5 months is improvement. And the progression-free survival was also improved in these patients, compared like 10 months or 11 months compared to 9 months. So this is the only positive finding of this trial. But probably this kind of treatment will not make it easily into guidelines. But sometimes, as you know, we are very selective when we apply this kind of treatment. Patients who are not tolerating chemotherapy, you need to give them chemo break or something. You need to bridge them to resection. Then you can apply this on individual basis. So the key messages here from my talk is RFA is plus chemotherapy results in progression improvement in progression-free survival, but no benefit on overall survival. It is associated with the lower complication rate, higher recurrence rate compared to resection, and should be reserved for very selected patients who have small lesions, favorable site for ablation. As for the microwave, less recurrence compared to RFA, similar efficacy in perivascular regions, but with higher complication rate in terms of biliary complications. As for the debris, it shows some probably promising future. It improves progression-free survival and overall survival compared to systemic therapy. It shows better response rates, less toxic than giving systemic chemotherapy, and it improves quality of life. And in terms of the radioembolization, there's no difference in the progression-free survival or the overall survival compared to systemic chemotherapy. And it improves the response in the liver specifically. However, it is associated with more adverse events. And in terms of right-sided primaries, it may improve, I would say, it may improve progression-free survival and overall survival. Any questions? Thank you so much.